Good morning. My name is Crystal Cohens, and I'm the Director of Clinic Partnerships and Business Development here at MAVEN Project. Thank you all for joining us today, and a huge thank you to our friends at Charles River Community Health Center for hosting today's session, Updates in Pediatric Asthma with Dr. Benjamin Nelson. Dr. Nelson is an Assistant Professor of Pediatrics in the Division of Pediatric Pulmonology at Mass General Hospital for Children. Dr. Nelson received his medical degree from Georgetown University in 2005. He completed his pediatric residency in 2008 and pediatric pulmonary fellowship in 2011, both at Massachusetts General Hospital for Children. He subsequently joined the pediatric pulmonary staff at Mass General and then became an associate program director for pediatric pulmonary fellowship in 2012 before becoming the program director in 2015. In addition, he is the director of the Pediatric Bronchoscopy Program and the director of continuing medical education in the Department of Pediatrics, which he oversees all CME programs. In addition to his clinical responsibilities, Dr. Nelson has built a career focused on medical education. His areas of focus are evidence-based medicine, trainee well-being, recruitment, and workforce issues. With that being said, I introduce you to Dr. Benjamin Nelson.
Thanks so much, Crystal. And thanks everyone for joining here today. Very privileged to be here with you guys. Let me go ahead and share my screen here. Here we go. And I'll call up my slides. And I should be able to see questions that pop up in the chat. So feel free to type those in at any time. I'm going to go through a number of cases with you guys and topics and hopefully leave plenty of time for some questions and answers as well. So why don't we go ahead and you can see this, Crystal? We're good?
Yes, everything looks good, Dr. Nelson.
All right, perfect. Thank you. All right, let's go ahead and get started. So I have no disclosures about this topic. And I think Crystal already talked about the accreditation for this session. So definitely claim your credits. And so over the next, 30, 45 minutes here, we'll talk about the most recent national asthma guidelines, how I think about them, how I interpret them, and how to apply to patient care. We'll identify which patients can use medications intermittently for their asthma versus which patients need more of a daily basis for prevention. We'll talk about adverse effects from commonly used medications, potential alternatives, and I just recently updated these slides to talk about potentially any insurance issues that you guys might be having and struggling with, like everyone is across the country right now with these medications. Okay, so let's start here. So let's say you're saying a 15-year-old male in your office, and he says that he's coughing with colds. It's a dry cough. It's worse at night. Triggers include usual stuff, viral illnesses, potentially exercise. The key is he's well in between viral illnesses. He responds well to bronchodilators and oral steroids. And he had 3 ER visits last winter, and he received oral steroids each time. So, question to you guys, and feel free to go ahead and type your answers in the chat. How would you treat this patient if you saw them in clinic? Would you put them on a bronchodilator? Would you use inhaled steroids? If you did use inhaled steroids, would you give them daily, intermittently? Would you combine with a long-acting beta agonist? Would you do something else? Or maybe transfer to your partner's schedule? I'll give you guys a second to type in your response. Let's see, I don't see any responses coming through so far. So either you can't hear me or you need more coffee.
Dr. Nelson, I do not see any questions or comments in the chat.
Okay, can you, they can hear, can we confirm that they can hear and see and everything?
Can someone please
Oh,
type
I
in
see
the
someone
chat?
answering. Here we go. I
Okay.
got an answer. Sorry, guys. I just wanted to make sure everyone could hear.
Awesome.
And I see different answers coming through, and that makes sense to me because there are different ways to approach these types of patients. And so what I'll do here is I'll talk about some of the evidence that led to the guidelines, what the guidelines recommend, and then also how I tend to go through this as well. So really what this comes down to, and the most common patients you guys are going to see in your office are those with intermittent viral-induced cough and wheeze, meaning when they're sick, but then they go long stretches of time in between illness without any issues. And there's two types of patients to consider here. Those who are not on a controller at baseline, and then we'll talk about who would benefit from intermittent use of inhaled steroids versus who would need daily use. And then those who are on a daily controller at baseline, what do you do when they become symptomatic? And we'll talk about evidence behind doubling the dose of inhaled steroids and whether or not that's beneficial. So why is intermittent inhaled steroids a thing other than the fact that a lot of patients do this anyways, even if we ask them to use the medications on a daily basis? It's really that we're worried about side effects. And we know some data here, but we don't know all of it. We know that for height, if you use too high of a dose, really medium to high steroids for long periods of time, and you don't decrease based on severity of disease or time of year, you could see a slowing of the growth. And when you see a slowing, you tend to get a prolonged duration of growth. However, the data suggests you might lose about half an inch of what you otherwise would obtain. Now, for some people, half an inch isn't that big of a deal. Me personally, you can't tell because I'm sitting down, but I'm only 5'6.5", and I'd like to be 5'7", and so I would love that extra half an inch. So I take that seriously. But if you are aggressive in weaning the dose over the summer months and their time of year when they don't really need that higher dosing, I tend not to see problems with height. There are reports of adrenal suppression, although in practice I really don't see it. And I don't think we know enough about bone health and long-term use of inhaled steroids. There really isn't any data there. And then the question becomes, is it a cumulative dose over a lifespan or the high dosing that leads to problems? And I think it's really the latter. I think it's really the high dosing. There's no data per se on this, but I don't see evidence in my practice of side effects from cumulative dosing. It's really the high dosing that I see problems with. Is it effective? We'll talk about the data there. And remember, is it fair to the family? If you're telling them to use inhaled steroids on an intermittent basis, you're telling them to make the decision when to start and stop these medications. And for some families, they're very good at this and it's no problem. But for other families, it can be quite anxiety provoking. They might not really understand when to start and stop. And so it might not be the right approach for every family. I like to keep things really simple and I like to be as straightforward as possible. I find that the more complicated we make our asthma action plans, the more steps there are, the more likely that it'll be hard for the family to follow. So let me take you back to the first real studies here looking in pediatric patients at intermittent use of inhaled steroids. This was the Trexa study back in 2011, and they looked at patients down to 5 years of age who had mild persistent asthma. And what they showed was that if you were on intermittent inhaled steroids versus daily, you had more treatment failures. However, inhaled steroids plus albuterol for rescue, so intermittent use of inhaled steroids, was more effective at reducing exacerbations than albuterol alone. So their conclusion was that intermittent inhaled steroids might be an effective step-down method, but really couldn't be recommended over daily inhaled steroids for all patients. Then around the same time, we had the MIST trial. So this was looking at children all the way down to 12 months of age. Almost 300 children were in the study, and they had a low degree of impairment, which is key because we're not talking about patients with moderate to severe asthma. We're not talking about patients who are in the hospital getting multiple courses of oral steroids each winter. These patients are really mild in their level of impairment. And what they did was they gave them budesonide for 1 year. So either a low dose regimen, so 0.5 milligrams once a day, kind of baseline regimen for prevention, or an intermittent high dose regimen where they gave them 1 milligram twice a day for 7 days at the onset of illness. So the huge dosing, huge dose increase compared to your regular baseline dosing. And what they found was that daily low dose budesonide was not superior to intermittent high doses. Therefore, using intermittent inhaled steroids might be effective in a certain population. So then about 7 years later, there was this trial looking at children down to 12 years of age. Again, mild asthma. And now here, they had 3 arms. They had a daily inhaled steroid plus a short-acting beta agonist, like albuterol, budesonide formoterol, PRN. So budesonide formoterol is Symbicort, and formoterol is a long-acting beta agonist that has a similar onset of action to albuterol, meaning it kicks in right away. And that's why you can use these types of long-acting beta agonists on an intermittent basis and for rescue. Whereas the long-acting beta agonist in Advair, which is fluticasone salmeterol, excuse me, the salmeterol has a longer onset of action, or of a delay of action, I should say. And so you really can't substitute those two long-acting beta agonists when you're using inhalers on an intermittent basis. And they found the same thing, that daily head-to-head daily use of inhaled steroids is most effective, but as needed inhaled steroids is better than a bronchodilator alone. And the way I think about this, it makes sense in that it really does take a good 4 to 6 weeks of daily use of your inhaled steroid before you reach that peak maximal protective effect. And once you stop the medicine, it washes out of your system after about 48 to 72 hours, and it's like you never took it. And so that's why daily use is most effective, but you will get some benefit right away. And that's why we think that the use of inhaled steroids on an intermittent basis in select populations can be beneficial. And I'll go into more detail of which patients in a minute here. So this is the bottom line takeaway. However, short-acting bronchodilators, so albuterol alone, may be good enough for some patients. I'm sure all of you have some patients who use albuterol from here and there, and if they're doing well on that regimen, there's really no need to change, just to put them on a guideline. If they're doing well, then continue with that. Okay, before we get into the guidelines here, I wanted to talk about doubling the dose of inhaled steroids because I do see this a lot. So these are the patients who are on low dose inhaled steroids at baseline and become symptomatic. And a lot of times in practice, people will say, double the dose of the inhaled steroids in the setting of colds. There was really never any data until a few years ago on this. And this group looked at almost about 250 children down to 5 years of age who had mild to moderate persistent asthma, and they all required at least 1 course of oral steroids in the last year. They followed them for about a year, and at baseline, they were all on fluticasone 44, 2 puffs twice a day. And what they did was they either had them continue the same dose during the exacerbation, or they went all the way up to 220 micrograms, 2 puffs twice a day for 7 days at the early signs of loss of asthma control. And what they found here was there's really no difference in the number of exacerbations between the two groups. The groups that got the higher doses of steroids actually didn't grow as well during that time frame. And there was no significant difference in use of prednisone or albuterol between the two groups. So the bottom line here, and my takeaway, is that if a patient is on an inhaled steroid at baseline and they develop symptoms, don't have them increase the dose of their inhaled steroid. I don't think it's effective, and you can run into a problem where they run out of the inhaler before the end of the month and then have trouble refilling. So in exacerbations, I use bronchodilators. If those aren't effective or they need something more, then I go right to prednisone. And if they're needing prednisone, I always reevaluate, is their daily preventative control or regimen appropriate? Do I need to change? How do I think about that? That's very different than patients who are on nothing at baseline and then starting inhaled steroids with the setting of colds. And so that's why I kind of broke them out in those two different groups there. Okay, so that's the background data that kind of feeds into the new asthma guidelines. So the GINA, there's actually multiple guidelines, which makes things even more complicated. So GINA came out with the fundamental change to reduce the risk of exacerbations. And they said that adolescents and adults should no longer use a short-acting bronchodilator alone. So this is a huge change. They say that you should receive either symptom-driven or daily corticosteroids. And this is key here. Whenever you're looking at guidelines, you need to know kind of what's their audience and what's their goal. And this was a population level risk reduction strategy, meaning they're trying to reduce exacerbations for the population at whole. And so sometimes it can be hard to extrapolate down to the individual patient. They say that early treatment and improved control can lead to higher remission and lower recurrence, which makes sense. And the hope is that we could potentially prevent airway remodeling and improve lung function in long term. Those are the goals. Now, here's the actual diagram, and I kept this small on purpose because I don't want to get lost in the weeds here. I want to start with step one. So this is looking at adolescents and adults 12 years and up. And they say in step one, you should use an as-needed low-dose ICS formoterol or a low-dose inhaled steroid such as fluticasone, although they don't specify that one, taken whenever you take a short-acting bronchodilator. So they're saying don't use albuterol alone in step one anymore. They're basically saying the same thing for children 6 to 11. They don't talk about ICS formoterol here because the study wasn't done in that age group. But they do say basically just use intermittent inhaled steroids in conjunction with your short-acting bronchodilator and don't use albuterol alone. And then for children 5 and under, they didn't make any recommendations and said there was no changes. So then to make things even more complicated, we have these guidelines that subsequently came out about a year later from the National Asthma Education and Prevention Program. And here they say step one, albuterol alone is totally fine. It's really not until step two and above where they start talking about intermittent use of inhaled steroids. And the goal for these guidelines were really to drive policy, and these are guidelines where they started talking about smart therapy, which I'll talk to you about in the next few slides. And so the reason why, well, one of the reasons why these guidelines are different is that they really have different goals. So this is my takeaway, and I believe you guys will get these slides as well. This is the way I think about patients with asthma. If they have persistent symptoms, meaning they're regularly symptomatic and their symptoms are interfering with their daily activities, either not letting them sleep at night, they're not able to go outside, they're not able to fully participate in exercise and sports, if they're in the ER getting systemic steroids, those are the patients who need a daily controller. For patients who really have intermittent symptoms, meaning they go long stretches of time in between viral illness when they're totally asymptomatic, I do think it's perfectly reasonable to treat these patients on an intermittent basis. However, I do split this group up into two categories based on their risk and impairment. Meaning, if I have a patient who gets 2 colds all winter, but ends up in the hospital both times, I'm probably going to put them on a daily controller throughout the winter. But if I have a patient with 2 colds throughout the winter and needs some albuterol, maybe misses a couple of days of school, they're much less risky in terms of their asthma severity. Those are the patients, and those are the vast majority of patients that you guys will probably see in your practice. Using intermittent inhaled steroids is perfectly reasonable. And I have a low threshold to start daily controller if they develop exacerbations. I follow these patients a little bit more closely. I'm probably going to be seeing them every few months throughout the winter to make sure that the regimen is going well. And remember, this approach does not work for every patient. And so if I'm telling someone to use their inhaled steroid on an intermittent basis, what I try to keep it as simple as possible. And so if I have them using albuterol and fluticasone, for instance, I'll say, when you develop a cold and you think you might need that albuterol, start both the albuterol and the fluticasone. Give 2 puffs of albuterol, followed by 2 puffs of fluticasone twice a day until the symptoms resolve. You can use albuterol more frequently if you need to. And if it's only for a day or two, that's fine. If you need it for a week, that's okay too. If you're using an ICS-LABA as your intermittent use of inhaled steroids, which is also appropriate, then I would just use the one inhaler and say take 2 puffs twice a day until your symptoms resolve. That's how I tend to do it. I'll show you how the guidelines break it down in using the inhaled steroids intermittently. But again, it comes back for me. You got to keep this simple or patients are going to get overwhelmed. That takes us into SMART therapy. So SMART therapy really isn't until steps 3 and 4. And it's for patients with uncontrolled asthma who are on a daily ICS-LABA and using a short-acting bronchodilator as needed. And so switching to SMART, which means same maintenance and reliever therapy, what you do instead of using the short-acting bronchodilator for rescue, now you use the same ICS-LABA for rescue. We talked about the onset of action for formoterol and why you can't extrapolate to other ICS-LABA preps. And what they say here is that to take one inhalation whenever you need to for symptom relief. And the maximum number of puffs you can take depends on your age. If you're young, 4 to 11, you can take 8 extra puffs throughout of the ICS-LABA throughout the day. And if you're over 12, you can take 12 extra puffs. There's a good safety profile, and it seems to be effective. The hard part here, though, is that in the United States, SMART therapy is not FDA approved. And so although budesonide formoterol is approved in this age group, SMART therapy is not. And so you can imagine if you're using 2 puffs twice a day as your baseline, plus using it for your rescue, you're going to run out after a few weeks, definitely before the end of the month, and you might not be able to get the insurance to cover a refill. And so although SMART therapy seems to work and be effective, it can be really hard to implement. The one time, so the times when I have them use their budesonide formoterol like a rescue is if they're either not on anything at baseline, or if you're using the budesonide formoterol once a day, then you should have enough to last you 2 months. And if you tell the patient to pick up a new inhaler every month, they can start to stockpile a little bit, and then you have more wiggle room. It's a little bit cumbersome, and that's why I try to keep things as simple as possible. And the bottom line is if they're well controlled, let's see, if they're well controlled, you don't need to change. Okay, so there's also smart exercise. It's not just smart to exercise, because that's healthy, but they talk about the use of ICS-LABA and exercise too. And believe it or not, the study actually goes back to 2014, but I don't think it really kind of caught on until the smart therapy started to become more prevalent in practice. And what they looked at was the use of 3 different arms: albuterol alone prior to exercise, daily budesonide, so putting someone on daily inhaled steroids plus a bronchodilator prior to exercise, or the use of an ICS-LABA prior to exercise. And what they found was that pre-exercise, using budesonide formoterol was actually more beneficial protecting against exercise-induced bronchoconstriction compared to a short-acting bronchodilator alone. And at 6 weeks, it was non-inferior to daily use of inhaled steroids. And so if you have a patient with mild exercise-induced bronchoconstriction and albuterol alone is totally working for them and allowing full participation, no need to change. However, if they are still having some challenges, instead of jumping to daily use of inhaled steroids, what you could try is giving them budesonide formoterol, having them use that prior to exercise, and that might be enough. Okay, just keeping track of time here. So Decadron in the ED. I wanted to just put up a slide here. I can't see you guys, but my guess is that a lot of time you get patients sent to you for follow-up from the ER where they had an exacerbation, they got a dose of Decadron, and they said follow up with your primary care provider the next day. And the problem here is there's no great data to tell you how do I think about those patients? Do they get more Decadron? Do I change them to prednisone or prednisolone? And so I'll tell you, I'll show you some of the data and then kind of what I do in practice, because I find this coming up more and more because Decadron seems to be the go-to medication now in the emergency rooms. So this study looked at prednisone 3 to 5 days versus dexamethasone 1 to 2 doses in the ER. And they showed that they were fairly equivalent, but that's hard to interpret because the range of both go from 3 to 5 days and 1 to 2 doses. And you can see their endpoints here: unplanned clinic visits, return to ER, and admission. All important endpoints. However, with asthma exacerbation, something that's really hard to capture in studies are what I would say very clinically relevant endpoints, such as is the child going back to school? Is the parent going back to work? Is the child sleeping at night? Back to participating in activities. Those are harder to measure, but I think equally important as returning to the clinic or the ER. This study here looked at prednisone at 1 milligram per kilogram per day, and you can see here the dose of dexamethasone, and they showed equivalent scores at day 4. This one looked at prednisone for 5 days, a little bit higher of a dose on the first day, but then a lower dose on the second day, a higher dose of dexamethasone here. So you can see these studies are really kind of all over the place. And how do you interpret that? And how do you use that as someone caring for these patients in your clinic? Now, the other question you have to ask yourself is, what is the difference between dexamethasone and Decadron versus prednisone and prednisolone? Now, Decadron, dexamethasone does have a longer half-life, but what we don't know is just because it's sticking around longer, is it still having that clinically relevant effect of decreasing the inflammation in the lower airways? We know it does for the upper airway, but we don't know as much about for the lower airway. So it's hard to say that 1 dose of Decadron equals 2 doses of prednisone or 3 doses of prednisone. We just don't know is the bottom line. So how do you put this into practice? So this is how I think about it. If the patient's low risk and they're asymptomatic the next day, meaning they're not coughing, they're not wheezing, they don't need regular use of their albuterol, they're probably fine, and you probably don't need to give anything more in terms of systemic steroids. If the patient is low risk but symptomatic, so they're coughing or wheezing, they have some signs of lower airway inflammation, they're not back to baseline, I don't see much downside, and I see really only benefit of giving 3 days of prednisone. And I usually dose outpatient 1 mg per kg per day. I save 2 mgs per kg per day for ER and inpatient dosing. And I tend to max out at either 40 or 45 milligrams per day of prednisone based on whatever's easiest to dose, whether you're taking pills or liquid. Because I find in the outpatient setting, anything more than 40 or 45 milligrams probably isn't necessary. If a patient is high risk and asymptomatic, so that means this is someone who has been admitted multiple times, they're high risk for exacerbations, I don't think that 1 dose of Decadron or dexamethasone is sufficient, and I'll give them 3 more days of prednisone, even if they're asymptomatic. And then if they're high risk and they're symptomatic, then I might give a higher dose of the prednisone for 3 days. I want to be clear that this regimen that I came up with is not evidence-based, but there really is no evidence in the literature to help guide us. And so this is how I kind of think about things. Okay, I put this slide in here to just say that we're all struggling with this right now with insurance and availability of medications. And I'm happy to answer any and all questions you guys might have here. It maybe what I'll do is I'll go through one more topic and then leave that for questions. One thing I'll say is, because we've been doing a lot of advocacy here, is that as of just a few weeks ago, Mass Health has now agreed to cover generic Flovent, so fluticasone, for all patients under the age of 12 without a prior authorization. And that's new because they weren't necessarily doing that as of last month. So at least for patients with Mass Health, if they're under 12, you should be able to get fluticasone covered for them now. Okay, then I wanted to touch base on step-up therapy, and then we'll leave plenty of time for questions and comments. So really the best study that we have on this is the Badger study. It's back in 2010 now. I put a picture of Bucky Badger here, not because the study was from Wisconsin, but I grew up in Milwaukee in Wisconsin, and I'm still a Wisconsin fan, and I like the name of the title. So that's why I put Bucky there for anyone who might have Midwestern roots at heart. So what they did was they looked at asthma exacerbations, asthma control days, and lung function, and they looked at the frequency of responses to three separate step-up therapies. So it was a randomized double-blind trial at 100, looking at 180 kids, and they had poorly controlled asthma. They were on low-dose inhaled steroids at baseline. And what they did was they either increased the dose of the fluticasone from low dose to medium, added on a long-acting beta agonist, and at this time, really the only thing available was the salmeterol, or they added in montelukast. And each patient got 16 weeks of each arm in the trial. Now, just to talk about the ICS-LABA and the safety issues, there are 3 different preparations here. They all come as an MDI now. My personal bias is if I can avoid it, I never prescribe a dry powder to any patients because I think that it's just really hard to take on a regular basis, especially for younger kids. The data will suggest in some of the studies that you can take a dry powder down to 5, 6, 7 years of age, but in regular clinical practice, I don't believe that. The hard part is a lot of insurance companies are trying to funnel our patients into using dry powders, and it's a really, really a big challenge. So I want to just be clear that there's new data now looking at long-acting beta agonists, which wasn't necessarily the case when I was in training. So the real problem here was using the long-acting beta agonist without the inhaled steroid because there was increased risk of serious asthma events, including death. They thought it was due to unsuppressed airway inflammation. It was greatest amongst young patients. But initially, they found that it really wasn't associated the same way as long as you were taking an inhaled steroid at the same time. And so studies were done, and I'll show you those in a second. We know that LABAs with an ICS work and they're effective. They reduce symptoms, they improve lung function, they reduce the risk of exacerbations, and they do minimize the required dose of inhaled steroids needed to control your asthma. Now, when do you use a LABA? I think that the benefits outweigh the risks when used appropriately. It's usually reserved for patients who can't be managed with an ICS alone. It has to be administered with an inhaled corticosteroid. You can't prescribe just a long-acting beta agonist anymore. And if you're getting to the point where patients need long-acting beta agonists on a regular basis, think about referral just because they tend to be more symptomatic and more high risk. As far as safety goes, this study is looking at patients above 12, and they looked at time for first serious asthma-related event, and they found no difference between the fluticasone group and the fluticasone salmeterol group. Then they went down to 4 years of age as well. And so they only looked out a year afterwards, but I feel pretty comfortable saying that the use of long-acting beta agonists now in children is safe and effective. Leukotriene modifiers, just a quick slide here. They can be used as monotherapy for some patients, but head-to-head, it's not as effective as inhaled steroids. So, however, we all have some patients who either the family won't do inhaled steroids, or they can't sit still for a nebulizer, they can't cooperate with an inhaler and a spacer, and it's better than nothing. So these are patients, think about it, for low risk, low impairment. It's a better response with the younger they are and the less duration of their asthma. It's been shown to be effective in patients who are obese and overweight, patients who are either smokers themselves or are exposed to secondhand smoke. But again, it's not recommended as a first-line controller. And as you guys may know, the side effects for montelukast are rare but real. I can't give you data on how often this happens. I can't tell you which patients are more susceptible to the side effects. So what I tell patients is that if it happens, it's not subtle. It's an obvious either change in behavior from one side of the spectrum where they really are depressed and don't want to do anything to more commonly aggression and acting out. You can also get nightmares. And if you see them, they usually come on within the first week or so of starting the medicine. And what you do is you stop the medicine, the symptoms go away. And from what I know, there's no long-lasting effect. Some patients are fine starting this medication. Some families aren't, and that's okay. The one absolute contraindication that I have is if a patient has a significant mental health history, so depression, anxiety, if they've ever have self-injurious behavior, anything like that, I would stay away from a leukotriene receptor antagonist. Other than that, I feel comfortable starting as long as I have this discussion with families. Okay, so jumping back to this study. So what they found was that basically everyone had a positive response to at least one of the 3 treatment arms. Unfortunately, baseline characteristics did not predict therapy most likely to be beneficial for an individual patient. If you took all comers, the addition of the long-acting beta agonist was most likely to provide the best step-up response. But plenty of patients did well on increasing the dose of the inhaled steroid or adding in the leukotriene receptor antagonist. So the big takeaway, I think, from this study for me is that if you have a patient who's uncontrolled on low-dose inhaled steroids, you have multiple options. And you tailor it to the family, whatever's going to be easiest for them. And then have them come back to your office 4 to 6 weeks later to reassess response. And if they're doing great, fine. But if they really haven't shown much of a response after a good 4 to 6 weeks, then instead of continuing to escalate and add on other therapies, go back to your low-dose inhaled steroid and try one of the 2 arms that you hadn't tried before. And that is all the slides I had today. I am happy to, and I listed all the places that I see patients as well as my email. I'm happy to hear from you guys at any time and would love to entertain questions. I'm happy to talk about anything we discussed here in this talk, other pulmonary related issues, or anything that could be most helpful for you guys. Now, Crystal, are people able to unmute themselves and ask questions, or is it best to type it in the chat?
Either, whatever is most comfortable for the attendee. If you'd like to type the comments in the chat, we're happy to respond to them there. Or if you would like to verbally communicate your responses, I can unmute you to speak. All right, if there are no questions, I just want to emphasize to ensure that you complete your CME survey correctly. The CME survey will appear in the tab when you close out this webinar. We really appreciate you taking the few minutes to complete this. Not only does it give you CME credit, but it also helps us to plan the best sessions for you. We share the feedback anonymously with our speakers, and they greatly appreciate your thoughts. Also, we hope you enjoyed today's sessions. And if you're interested in attending future sessions or even anchoring in an educational session, all clinics can anchor an educational session, which means you get to pick the topic, the date, and time of any session. The only requirement is that someone from your clinic attends the session. So if you're interested in becoming an anchor clinic, we would love to schedule you a session. You can either submit the educational session request form on your clinic portal, or you can email Kristen Talbot, our program manager, and I'll be sure to drop her name and contact information in the chat. Hopefully you enjoyed today's session, and within the next 2 weeks, the recording will be placed on our community portal under our on-demand library with all of our other recorded educational sessions. We did have a comment from Lynn. She said, very practical and clinically useful. So thank you, Dr. Nelson. And we have several other comments from some of our attendees that just said that this was great information. It was a great talk, and I also concur with their assessment.
Oh, well, thanks. That's very kind. Yeah. Please feel free to reach out if I can help with anything going forward.
All right. Thank you so much, Dr. Nelson. I hope you have a great rest of your day.
Bye-bye.
Take care.